talk now about cardiovascular emergencies, which is why I had you guys do this project and had it be ready for today's class. Okay? So I'm hoping that there can be some, won't you guys slide down that way? I'm hoping that you can look at your 3D model, if you will, and kind of understand a little bit now that you understand the flow of blood. Do we need to review that part before we get started of the circulatory system? Anybody need to review it? You're all good. Okay. Do you need to review real quickly the circulatory system by how the blood flows through the body and the heart? Okay. Well, let's go ahead and get started. Why is it not working again? All right. So, cardiovascular disease. Here's some very sad statistics, actually, y'all. Hang on. All right, this isn't working. Okay, 63,400,000 Americans have one or more forms of cardiovascular heart blood vessel disease. That's a pretty alarming number when you start thinking about, the amount of calls that you're going to get for one of these emergencies, right? Everybody wants those good trauma calls, but the fact of the matter is these are typically more challenging, and you're going to run into it a lot more. Okay? 50% of all the deaths are cardiovascular, all right? Because what all falls under cardiovascular? What can you think of that might fall under a cardiovascular cause? Heart attacks? Difficulty breathing could. Well, angina, sure. Hypertension, hypotension. What else? Oh, stroke. Stroke's a pretty big one. Okay. So, the acute myocardial infarction, or AMI, most of us kind of refer to it as MI. So the MI is the leading cause of death in the U.S. And believe it or not, they are getting younger and younger, folks. One of the youngest I believe they've had on the cath lab table at Scott and White was 24. How old are you all? 30. I didn't mean for you to really tell me. Rhetorical question. Okay, so how many of you fall into that category anyway? Okay, so be thinking about that. 1.5 million Americans will have an MI this year. Okay, now here in the great state of Texas, how do you think we fare with MIs?
Pretty high.
Why?
Fried food.
Diet. Yeah, absolutely, diet. Red meats, that kind of stuff. Okay. And then of that 1.5 million, the 500,000 will die. Okay, again, pretty alarming numbers when you start looking at it across the nation. All right. Now, 350,000 die in the first 2 hours. Somebody who has not taken this class before, what do you think the average time is for someone to call for help?
Half an hour.
3 hours.
I noticed that patients, how long do they have to stay? A day or?
Hang on, guys. Be respectful. Say it again, Cody.
I've noticed that with a lot of patients coming with chest pain and think they're having a heart attack or something. And when did it start? 5 hours ago. You just now coming in.
Absolutely. So yeah, and we're going to talk about some of the reasons that they probably delay care, okay, and some of those other issues. So cardiovascular disease, there's some acute coronary syndromes, and that's what they'll call it. So while you're doing your ER rotations, they're going to talk about ACS, ACS1, ACS2, that kind of thing, okay? That's just kind of like the catch-all for acute coronary syndromes, okay? Acute myocardial infarction falls into that. Now, there's two kinds of heart attack or MI to have. There's the non-STEMI and the STEMI. The non-STEMI is a non-ST elevation MI. Now, when we start talking about ST elevation, what they're talking about is how it looks on a 12 lead. They'll have 12 lead changes. So when they use their EKG machine and they look at that 12 lead, so basically a bunch of different pictures of the heart, that's what they're talking about. But remember, there's the STEMI and the non-STEMI. So when you get out there in the field, just because they don't have changes in their 12 lead does not rule out a heart attack. It can only rule it in if they have it, but it can't rule it out if they don't. Does that make sense?
Yes.
Okay.
Question on that.
Okay.
So when you get a non-STEMI, I mean, are you saying that tells you that they're, by the readings, that they were accurate, that they're not having a heart attack?
No. So this is still a non-ST elevation MI. So it's still an MI. So when they get to the ER, they start running some cardiac labs, like a troponin, like a CKMB sometimes, okay? That troponin is really the way that they start determining and diagnosing whether this is angina, unstable angina, MI, infarct, injury, this kind of stuff. So you have to have lab work. And the point of that is not everybody who is having a heart attack will show it on a 12-lead EKG. So you can't look at a 12-lead EKG. I can't. The physicians can't, okay, base it just on that 12-lead and go, there's no elevation, they are not having a heart attack. They cannot do that. Does that make sense? Excellent. They also have unstable angina and stable angina. Sorry, guys, the clicker's not working again. So let's talk about some risk factors. How many of you guys think raise your hand if you know a risk factor?
Age.
Age,
Diet.
diet,
Movie.
yeah.
Gender.
Say it again.
Gender.
Gender, Brian. Race,
Exercise following
exercise, smoking. All right, let's see how many of these we got right. Let's see, kind of how well we know some of our stuff. All right? So risk factors. Major uncontrollable. So what does that mean?
Something they can't control.
Right, they have a significant impact on our cardiovascular health, and we have no control over it. That's kind of scary, right? When you start thinking about those numbers we were just talking about. Age. Who said age? Excellent. Gender. That one went to, okay. Race. Did you guys look over your slides?
Yeah.
I'm so proud.
it.
You read it.
Hereditary. So that basically kind of means it runs in my family. Okay. Major controllables. So like, what do I have control over? Let's see, because we're talking major ones, right? Major ones that are going to have a big impact that I can control. Let's see how close we are. Smoking, on point. Smoking is going to have a huge impact on not only heart attacks, but strokes as well, because of the cardiovascular compromise. High blood pressure, right? Because we can control that, but it's got a significant impact. High blood cholesterol, okay? Diabetes. Talking to y'all, okay? Uncontrolled diabetes. Now, this doesn't mean I can control whether I have diabetes or not. This means that I have the ability to control it or keep it within normal limits, okay? So, say again?
It's another thing you gotta worry about.
It is another thing y'all have to worry about. Unlucky you. I'm sorry for you, man. All right, minor controllables. Let's see. Obesity. How many of you guys would have thought obesity would have been a major controllable? Yeah, absolutely. I would have too. Lack of exercise. It's another minor controllable. Stress. That's minor controllable. So, I mean, it has an impact, but it's not as big as the impact of, hereditary, age, sex, smoking stuff.
I don't really like where I'm sitting with this. I'm just letting you know things are looking real bad for me.
Personality, that kind of goes along with that stress factor, okay? So, control of risk factors equals a decrease in the coronary artery disease and heart attacks, okay? So, this is your opportunity to educate yourself so that we can better educate not only our families but the communities, and because that's part of what we should be doing. That's why there's a big push, right? There's this big push. How many of you guys have went somewhere and either heard a stroke or a heart attack commercial, or have seen something hanging on the wall about know your risk factors? You saw it at your doctor's office, didn't you?
Yes, but not only that, today I was watching TV and there was a commercial about stroke.
Mm-hmm.
And Heather looks at me and she goes, "Did you know that was the risk factors?" I was like, "Yes, I knew that, but..."
Well, and part of what we need to be doing is educating people. Let's think about this for a second. 500,000 people are going to die from a heart attack. They wait 3 hours to call, but most of them die within 2 hours. So how many of this could we impact? Significant numbers, right? So we've got to work on some of the things that they choose to not call or come in for in a timely manner.
It surprises me that they don't put that information on a commercial. Like, if you wait 3 hours, 3 hours could be too late. You know what I mean? Like, why aren't we putting stuff like that on a
I think that would probably be rather scary for most of the, for the public. And then you would also probably have people calling. Yes. You have those worriers. We actually had a patient who called and said they're having a AAA. You know why? She read it on WebMD and convinced herself she had the symptoms. Okay? All right, let's talk more about coronary artery disease. So what do we know about the heart muscle? It requires continuous oxygenation. Now, you guys remember, where does the heart, look at your models, where does your heart get its blood flow? Remember I told you had to draw 3 things on your heart. You guys remember? What were the 3 things you had to draw on your heart? The major coronary arteries, right? I'm not going to even make you name them. Circumflex. What else?
You said you weren't going to make us name.
I know, but he kept trying, so I was going to see who could help him out. That's okay. That's all right. So it's important to know that that's how the heart gets fed, right? And it has to have continuous oxygen. And it's real important that it has continuous oxygen because that's kind of the function that if you talk to a cardiologist and a neurologist, they're both going to think that the heart and the brain run the show, right? Blood flow passes through the coronary arteries. Atherosclerosis, narrowing of the lumen. Okay, and we're going to have a good picture of this. If you haven't looked over the slideshow yet, there's a good picture to kind of talk about this and to go into this here in just a second. But it can narrow by a few different things. So plaque formation, and that's going to be related to your risk factors, right? Cholesterol, diet, okay? And then, obviously, the result is decreased perfusion via the coronary arteries to the heart. Everybody with me?
Yeah.
Sir?
What is the lumen?
The lumen is the inside diameter. So if you look at my straw, this inside here, that's my lumen. The diameter.
Arteries.
Yes.
Okay.
So they're just talking about the inside diameter of the arteries in this case. Any other questions? All right. Poor tissue perfusion. What does poor tissue perfusion cause? Any question or any guesses? Hypoxia. Shock, eventually. Shock, absolutely. Tissue damage, right? And I think that's what you said, isn't it, Rick? Dead tissue?
Yeah.
So tissue damage, so you can even damage it, not necessarily kill it, and tissue death. And the difference here is ischemia is tissue damage, and infarct is tissue death. So now, what's the difference? We've already talked about a couple. Does that keep flashing?
Yeah.
Okay.
I know it's just me for a second.
So when we're talking about ischemia and infarct, what's the difference?
Damage and death.
Yeah, so significant. So that's why it's an acute myocardial infarction. That tells me that I've actually had death of the heart muscle, where ischemia would be more what? My anginas. Okay, and we're going to talk about those here in just a second.
Can that be anywhere in the body?
Those are global terms.
Yeah.
Okay, so here's the example for atherosclerotic plaque formation. So you see the interior lumen right here. Okay? Now look as the plaque builds up. Okay? And as the plaque builds up, what happens as plaque builds up?
The flow becomes smaller.
It becomes turbulent. You start getting this turbulent blood flow, right? And what else happens?
Stop.
Huh?
Eventually it'll block it off,
Right, but what else is going to aid in this?
as in, like, the blood flow, the way it's flowing, you're gonna get an inaccurate reading on.
You're going to start getting red blood cells that are kind of sticky, right? That are going to start sticking there, have the potential to start sticking to this stuff. And then you can kind of get that clog quickly, right? So some of it could be making it worse for blood flow, and blood flow can even kind of be part of the problem, right? So let's talk about angina. Angina basically means choking in the chest, all right? Okay. Okay. So the oxygen demand exceeds the blood supply during periods of typically activity, increased activity, exercise, or even a stressful event. Okay? When I get excited even. So here's what I want you to remember. If you look at somebody and kind of go, they look like they could be having some of these risk factors for a heart attack, even if they don't have any history and they have an emotional event, don't fall into that, oh, it's just anxiety, they're just excited, right? Because these things are going to increase my oxygen demand, increase my need. So if I have a little bit of buildup already, and now I increase the oxygen demand, it probably can't supply everything I need, because what happens is it can't dilate effectively. When we start clogging up the lumen, when that plaque builds up, it can't dilate to give me more blood flow, i.e. more oxygen. Do you guys see the problem?
And that's an angina.
It's in general. It can be angina or MI. Okay? So, increased activity, exercise, or a stressful event.
Okay, so basically what I understood is angina is basically either choking or a really bad pain in the chest.
We're going to get further into it.
Is the red showing like the pain? Or what is
Yes. I think that's kind of a diagram to show where the pain may go.
We had a lady come in today, and she was having chest pain for a while, and it radiated into her left arm on one side. She's a younger lady,
Mm-hmm.
and she's dealt with it for long weeks, and she'd always just raise her arm up above her head and take deep breaths and go away.
Well, that's going to be something different, and we'll talk about, when we start talking about signs and symptoms, I'm going to come back to that, okay? And we'll talk about that, Cody. All right? All right, so during stress, and this is kind of what we already talked about. During stress, the myocardium, which is the heart muscle, right, demands more oxygen, okay? And then the coronary arteries, normally, like on a healthy heart, they dilate, they increase the blood flow, which increases the oxygenation. Now I can feed the heart what it needs so that it can continue to work harder, because that's how it works, okay? And then when you have angina, the coronary arteries basically are unable to dilate because of this plaque buildup, right? So they don't get any bigger, therefore we can't increase the oxygen demand. Okay? They're in turn making it more hungry for oxygen. Everybody with me? Mickey?
Yeah.
Excellent. So, classic presentations. Going to be your chest pain. They can have shortness of breath. What is diaphoresis? Sweating. Okay? And then N/V. I'm going to come to you, Ashley. What is N/V? Do you remember? Did she go over that abbreviation with you? Sorry, Jesse.
No, I mean, I wish I had my little packet.
Nausea and vomiting.
Yeah.
Okay? Nausea and vomiting. Here's the
I have that to use that one.
Yeah.
Yeah.
Here's the problem. People don't read the textbooks. Okay? What does that mean?
Because they're not always going to present with the same symptoms.
That's exactly right. It means that they don't always present with those symptoms or the same symptoms, right? So, symptoms are pain, Usually it's substernal, which is where? Right underneath your sternum, right? Yeah? Are you listening?
Yep.
They're often tell you it feels like something's sitting on their chest, or it's squeezing, or a heaviness. You'll have a lot of people say, it's heavy for me to breathe. It's just, I don't feel like I can get a big breath. It's that heaviness that they're trying to describe. Okay? And can radiate, here you go, can radiate to the arms, shoulder, jaw, upper back, and then upper abdomen back. All right?
This is all she was having, but they couldn't figure out what's wrong.
Okay, hang on to it. We're getting there.
Keep going.
We're going with it. All right. Could also be associated with some nausea and shortness of breath. Okay? And sweating, like we talked about earlier. Pain's usually associated with the 3 E's. You guys remember what they are? Exercise, eating, and emotion. Way to read it, Sean. Good job.
Well, I was just pretending like I didn't know the last one. Even like I knew what was going on. So.
Exercise, eating, and emotion. Okay. So pain usually does not last greater than 30 minutes. Okay. Lucky for us. Usually, pain is relieved by a couple of things. It's going to be rest and nitroglycerin. Okay? So these are those people that are prescribed nitroglycerin, and they say, the doctor told me to take this whenever I'm having chest pain and sit down and rest, and it usually makes my chest pain go away. All right? So some of the symptoms that we may see, they may be quite anxious or fearful. Okay? Especially depending on how many of those commercials they've read, how aware they are of what their medical conditions are, and kind of, that whole thing, plus personality and all that plays a part. Okay? Fixation of the body. They may be pale or ashen. What does a livid face mean? Say it again. Yeah, like redness, right? Think about somebody who's angry, because that's what livid is, isn't it? Okay.
What do you mean by fixation of the
Thank
body?
you.
Fixated on stuff. Like, they can't get past... I've had to question people and kind of, what's going on? Are you having this or that? And they can't get past the crushing in their chest to be able to explain to me other things.
So they focus on what are the main...
Yeah. And then dyspnea, or shortness of breath, can be associated. Okay? Nausea. Diaphoresis, again. Okay? BP is usually up during an attack. Ryan, why is their BP usually up? You know why I'm asking you this question. Why was her BP up? And she's not even having a heart event, a cardiac event, but why was her blood pressure up? What did they do that brought her blood pressure down?
Give her meds.
What kind of meds? You don't have to tell me the name of the medicine. What was it for? Pain. For pain. They gave her pain medicine. It brought her blood pressure down. Okay? So following an angina attack, there's no residual damage done to the heart, right? It's that ischemia versus infarct. Is this kind of making sense to you now? Okay. Go ahead.
So angina is just like pre-heart attack.
Yes.
Okay.
It's kind of that.
If you catch it before you get to the heart attack stage, you're golden. It doesn't cause any damage.
Yes.
Okay.
Yes. So there's stable angina, and this basically occurs with exercise. Well, let me go ahead and... Okay. So generally, this stable angina is kind of... I live on the 3rd floor of an apartment. I know that when I walk up the stairs, when I hit the 3rd floor, I'm going to have chest pain. Right? I start having chest pain when I have to go out and mow my yard. Once I rest and kind of, just relax, take a nitro, it goes away. So it's very predictable. I know when it's going to start. I know what it takes to take care of it, and it's always the same. Does that make sense? Okay. Unstable angina is going to be more frequent or severe. It is not predictable at all. Okay? It doesn't follow that normal pattern, and it can occur during rest. So it doesn't take an exertion on my heart sometimes when I have unstable angina. Now this is inching closer to that heart attack. This is kind of like that, hey, you better wake up and pay attention, right? We got something going on here. Okay?
Question on that.
Sir?
I mean, I know that they both probably would, but would this one more preclude some health condition that's leading to that? Or could this also be hereditary?
Any of the above. We talked about all those risk factors. It can be any combination of those.
Okay.
Is that what you're asking me? I'm not sure I understand your question, Fraser.
I mean, I guess I'm wondering, like you say, it's this is the one that's itching closer to a heart attack.
Sure.
And like the stable angina, you can come to expect it, but with this one,
Right.
I guess the ways you can prevent it, is this more preventable? This is more in the realm of prevention?
Well, this one really isn't preventable because it can come on. Like, so if I have stable angina, I know how to prevent it, right? I don't exert myself. If I know I have chest pain when I'm mowing the grass, don't mow the grass. That's preventing the pain, but the condition is present. So we can do some stuff like lower our cholesterol and reduce our stress and stop smoking and control our diabetes, right? Those are the things that we do to kind of prevent.
Okay.
Does that make sense?
Yeah, I guess I was just curious about that one, because I mean, I know that one pretty much presents just like a heart attack.
They're all very similar, yes. Yep. Okay, any other questions on that one? Okay, so now let's talk about the big one, right? Anybody ever watch Sanford and Son? Elizabeth, it's the big one. I'm coming to see you. So let's talk about that. This is going to be inadequate perfusion of the myocardium. So this is when we actually have death of the heart muscle, right? This is why this is bad, bad news. Okay? All right. So remember, death of the heart muscle is called infarct. Damage to the myocardium is called, ischemia. Symptoms. Chest pain is, ma'am?
Is damage repairable?
Yes.
Okay.
So chest pain is the cardinal sign for an MI. All right. This occurs in 85% of all MIs. What does that tell you? I'm going to see if you're a pessimist or an optimist.
Not all of them are the same.
It tells me that 15% of people who are having a heart attack don't even have chest pain.
You don't know.
So they don't know.
Huh?
So they don't know.
We will talk about some of that. They do know. They have other symptoms, but they're symptoms that are very vague. Okay? So, generally it's substernal, okay? Very similar to our other angina and unstable angina, right? Crushing, squeezing, tight, heavy pain. Okay? What are those examples of?
Feelings?
When we ask them some specific questions. Huh?
Quality of the pain.
Yep, quality of the pain. Remember OPQRST? This is your Q. What does it feel like? All right? Did you already know that? Excellent. Okay, and again, it can radiate to all the same places as the other, chest or angina issues. Okay, may vary in intensity. It is unaffected by, here you go, Cody, unaffected by swallowing, coughing, deep breathing, and movement. Did your lady fall here? Was she unaffected by? Do you know what that means? Hang on.
She was saying how she's always gotten rid of it, because she holds her arm over her head, takes deep breaths, and it goes away.
Right. So does she fall into this? So would I have a high index of suspicion that she's having an MI?
No.
No. Because typically the pain doesn't go away when you either move or deep breathe. It doesn't change anything, right? You see what I mean? Okay. Now you with me? Excellent. Ma'am.
I have a question about this. If, somebody's saying they're having chest pain or whatever, and you palpate their chest and it doesn't affect it, is that the same?
Yes.
Okay.
So here's the thing. Let's think about the heart muscle, okay? But let's say it's my quad muscle,
Okay.
right? I have a sore muscle. I've been working it, and it's sore. If I touch it, does it hurt more?
Yes.
So my intercostal muscles will be the same thing, right?
Yes.
So my chest wall muscles, if I push on it and it hurts, it's probably going to be more chest wall pain rather than cardiac pain.
Okay.
See the difference?
Yes.
Okay. Not always, but it doesn't necessarily say, oh, nope, they're not having a heart attack for sure. This just kind of puts it down lower on my suspicion, okay, or higher on my suspicion. You guys understand what I mean by that?
I've had several chest pains, and that's why I asked that, because they always palpate, and sometimes they, yeah, that hurts, or no, that
Right.
doesn't hurt. So I was just curious.
Absolutely.
Her other problem she was having, complaining on, I don't know if necessarily with this, but she was asking if it was associated with, was random bruising. Like she would have a random big bruise on her thigh.
Huh.
She had on her breast, big ass bruise. And her husband didn't beat her or nothing. She said no kind of trauma or nothing. But
Mm.
she was saying that it just started within a week that she didn't have chest pain throughout the year.
I don't know. What was your question, Fraser?
Oh, nothing. I think I made my question.
Okay.
So, if they're unaffected by swallowing coffee, deep breath, or movement, that's basically going to give you a good indication that it's probably angina rather than an or MI.
No. It's going to make me think it's something other than cardiac pain, right? Because in my chest, I have a lot of things that can cause me pain. If I have pneumonia and I deep breathe, it's probably going to hurt. How many people in here have had pneumonia? Okay, did it hurt when you took a deep breath?
Yes.
Yeah. So that's going to make me think probably less cardiac, not ruling it out. Okay? So some of the things I want to know is, does it go anywhere? Does it hurt when you take a deep breath? How about when I touch you or push on it? Right? Guys, remember how I've told you guys as we do our assessments, we have to put hands on our patients? Guess what? Our medical patients are absolutely no different. Okay? Absolutely no different. The difference is, we just get to be a little bit more focused on what we want to look at. Yes, sir.
They were talking about normally, whenever she had chest pains, it would change whenever she raised arms over her head, but she came in because it didn't change this time. So would you be concerned with the heart attack?
You know what? I would always be concerned with a heart attack until they can get labs to rule it out. And I'll tell you why that is. Time is muscle. What does that mean?
The longer you wait, the more tissue dies.
The longer you wait, the more tissue that dies. Right? And that has long-term effects on me beyond this heart attack right here. Okay? And we're going to learn about some of those effects here in just a minute. Yes, sir?
This isn't really related to this class in general, but in regards to, I guess, the tissue dying
Mm-hmm.
in the heart, is there anything being done to be able to replace those pieces of
No.
it?
Once it's dead, it's dead. That's why time is of the essence. There are a few things that are actually time sensitive that we're going to deal with. Heart attacks are one. Strokes are one. What's the other one? We just learned all about it. Trauma. Trauma. Those are time sensitive. Significantly time sensitive. So time is muscle, time is brain. Okay, and I know we're talking predominantly about cardiac, but time is muscle. And that's the big problem. So if they let this heart attack go on for so long that it kills their entire left ventricle, yeah, what do you think their outcome is going to be like? Yeah, that's why we need to know that's why some of the things they need to do is they get them there quickly and they go to the cath lab. What does the cath lab do? Do you guys know? How many of you guys know what the cath lab does?
They place stents.
Sometimes they can also remove clots. So they can remove clots. So we have interventional radiology here. So they can place stents, which is basically like a little piece of mesh that they take in through the femoral artery, and they kind of go in, and then when they deploy it, it kind of pops open, and it holds that artery open. Interventional radiology for strokes can do things like put clot-busting drugs right there locally on it, so they don't have to use it systemically. They can also kind of remove some clots as well. Medicine is phenomenal.
Don't they also put in pacemakers in the cath lab?
Yeah, they can. They can.
It's like Drano.
Yes, it is like Drano. The problem is, and they have, you can still clog up a stent. So you have to be careful to change your lifestyles, otherwise you're going to continue to.
Then you go back, maybe
Yep.
have the same problem they had last time.
Yep.
By any chance, clear out some of the blockage?
Sometimes. But you got to be careful about clearing out that blockage. If it's, yeah, it could dislodge and throw off a clot, and then you've got a stroke, or you've got a PE, or you've got any of those other things that happen.
So when they would put a stent in, or a balloon or something,
Mhm.
in it opens the already clotted area? Would they,
Mhm.
they put it like right smack down?
Kind of swells it, yep.
Okay, and it opens it up. So
Yes.
You have like a little balloon section.
Yes,
there.
and they do some ballooning too, where they go in with the balloon and they blow it up and try to kind of push it all out of the way.
I didn't know if they removed the clot or the
Sometimes they can't because, again, you don't want a piece to come off. All right. Sorry, guys, I wish my clicker was working. All right, so symptoms: chest pain, unrelieved by rest or nitroglycerin, typically. Okay. Pain lasting longer than angina pain, and this can last up to 12 hours. Some of it's going to depend on the amount of heart tissue that's damaged, et cetera, et cetera. Okay? They can actually have a silent MI. We'll talk about that.
Is that why they call it the silent killer?
Yes. This is that 15% of people. Anybody want to guess on what you think they present? What do you think your signs and symptoms are? Brian?
They get kind of weak.
Say again?
They get kind of weak.
Possibly. Let's see. It's particularly common in females, elderly, and diabetic. Okay? So if you get a female diabetic who's elderly, if she is nauseous, if she's complaining of weakness, and they may have nothing but shoulder pain, or I'm just sick to my stomach, I don't feel well. Be very, very careful with those patients. Ma'am?
Oh, well, what I was told was it more like the flu?
Mm-hmm. Absolutely. So they're going to be that tired. Some, I just don't feel well. Some of them might complain of dizziness. Okay? Brian?
That's how my grandma was. She was diabetic too. And like she was having it, like the day before, her blood sugar was like really, really low.
Mhm.
It wouldn't come up above like 7.
what was the age you said that was common?
Elderly. Women, elderly, or diabetics.
Okay.
So it doesn't mean that only women, elderly, or diabetics fall into this. That means they have a higher risk of having atypical chest pain. Okay, or atypical MI.
Don't they say with women, if they say they have stomach pain, you should also consider it?
Yes. So a woman, that's what I'm saying. It doesn't have to be all of those. So a woman who's having, if you could add chest pain to her list of complaints and it would make you think MI, like if she doesn't have chest pain but she says, I'm short of breath and I'm sick to my stomach. If you say chest pain, short of breath, nausea and vomiting, if it makes you think MI, you probably need to be thinking MI on those patients. Does that make sense to you guys? Okay. Well, sure, they can cause altered mental status. It depends on kind of, okay, so as my heart dies, it doesn't pump effectively. What is that called? You guys remember what that's called? Okay. Yeah? No, not ventilation. So I have poor cardiac output, so my cardiac perfusion, right, it stinks. So my blood pressure falls, so I'm not perfusing my brain, so then I get altered. Okay, so that would be probably typically later in the MI, in the event.
It's gonna be a bad sign.
Yeah. Altered mental status, guys, is always a bad sign, no matter what the complaint is. All right.
Even if they're crazy, like, can't that just, you know what I mean? Like,
Nobody's ever just crazy.
nobody's ever just like schizophrenic.
Well, sure. But you know what? That's probably not going to kill him. Whereas if I don't take, if I don't take into account other things, that's just like that nobody's just drunk.
Okay.
Right? You see what I'm saying? You have to rule out medical causes before you can go, they're just crazy.
Gotcha.
Yeah, because I had a guy that said his history was he was schizophrenic.
Mm-hmm.
He was complaining of shoulder pain, and it turned out he had sickle cell.
Ah,
So they were saying it was a pretty big deal.
Yeah.
It wasn't just because he was crazy. Because he gave me a completely different like signs and symptoms list of like how his pain was, the quality, and everything, than the nurses and doctors.
You will find that they're going to do that. It's just going to happen. All right? So they can have shortness of breath, weakness, dizziness, or fainting. That's also called syncope or a syncopal episode. Okay? Nausea or vomiting. Pallor. Do you guys remember what pallor is? Who can tell me what pallor means? I know we talked about it in another lecture. Paleness. Yep, absolutely. And then diaphoresis or heavy sweating. Okay? They can have a sense of impending doom. How about those people who are in denial? Don't you think that probably plays a pretty big part on those people who wait 3 hours? Right? Because what are the 3 E's that bring this on? Eating, emotion, and exercise. How many people do you think who present with a heart attack or have cardiac-like symptoms have those symptoms right after eating and believe it to be indigestion? A whole lot. And they will treat with all kinds of stuff for indigestion, and it won't get better, and it won't get better, and they'll go, I don't know, and then somebody's going to end up calling, and now they've waited all of this time because they thought it was indigestion. Right? They're in denial. Oh, it's not me. I can't be having a heart attack. I'm 24 years old. Nope, nope, nope. All right? 50% of deaths occur in the first 2 hours. Remember, we talked about that. Okay? The average person waits till around 3 hours to call us. So what does that mean that most cardiac arrests that we work at home are? Yeah, too late. Who said that? Was that you, Sean? Oh, Rick? Okay. Say again?
DOS.
Yeah. Changes in blood pressure and respirations are non-diagnostic. Okay? That means there's no way to know what the changes are. So I can't tell you that they're always going to be hypotensive, but they're always going to be hypertensive. Okay? Early recognition is crucial. High index of suspicion, extremely important. Okay? When in doubt, manage it like chest pain. I'm sorry, like cardiac pain, like an MI. Okay? Because not doing that and having it be an MI costs them muscle. And it could cost them their life. Okay? So management. Begin management immediately if we suspect that they're having a heart attack. Well, duh, right? Of course we're going to do that. So you want to get a complete history and a physical exam as we treat. Okay? We don't wait till we do our head-to-toe assessment and do our ABC and wait till we're ready to roll back around, do our ABC and then our secondary, and then we don't want to wait till we roll back around to start doing something to treat these guys. We got to treat it as we go. Okay? How are we going to treat it? Let's see. Request ACLS or ALS. Put them in the position of comfort. Typically it's going to be sitting up, right? Because if they feel like they can't breathe already, all right? Make sure they have a patent airway, especially if they're nauseous or vomiting or have altered mental status. O2 to maintain SpO2 greater than 94. And you may give them a little bit, remember, if they have a complaint of shortness of breath. Okay? Reassure the patient. That doesn't mean reassure them, oh, I'm sure it's not a heart attack, you're going to be fine. What does reassure my patient mean?
We do everything we can for you.
Yeah.
We're going to get you to the hospital.
And you hit it hard, you have to stay calm. And it's real difficult because when you look at somebody and they are presenting like that, cardinal MI, they're sweaty, they're nauseous, they're diaphoretic, they're pale, they look like crap, they're complaining of chest pain, it radiates, it's not reproducible. But when they have all of these things and in your gut you go, oh boy, you realize that time is muscle. And if I don't do something quickly, right, I'm going to aid in their overall condition in the end, which is not where I want to be, but we have to stay calm. Okay?
They probably already know what you're thinking.
Yes,
You don't want to
typically.
display that.
But you know, I tell them, here's my concern. Ryan, my concern is that I think you might be having a heart attack. So I don't want you to get alarmed. I'm right here with you, and I'm going to be here to take care of you. But there's some things we need to do. I want to get a 12-lead EKG. I want to go ahead and give you some aspirin. I'm going to give you some nitro, see if I can't relieve some of that pain. Right? That's how you reassure them. A lot of it is going to be in your demeanor. But talking to them. Don't try to be sneaky. Right? Let them know. Okay? But we don't want to stress them out either. Sir?
I'm digressing some. Before we get too far on management,
Okay.
just a couple quick questions.
Yes, sir.
So, as an EMTB,
That's all right. Go ahead.
am I, it's gonna come out wrong. Am I concerned when I come up on somebody and he has signs and symptoms of either angina or MI? I don't care. He has signs of. Where's that? As an EMT, do I care which one he has?
What's the difference? Let me ask you
That's
that.
going to be my next question: is how can I look at a person and go? Because I'm looking at the signs and symptoms, and they're
Physical
almost all the
exam
same.
They're almost all exact.
Exactly.
And the things that aren't exact aren't going to be for sure. So what are some of the differences that you guys can recall?
I would think the main difference is just time.
Yeah, how long has it been going on?
Yeah,
What helped it get better or not?
30 minutes, and then the other
Right,
ones-
because typically your heart attack doesn't get better with rest or with nitro. Those are some of the things that I ask my patients, right? They go, this has been hurting me for 3 hours. What were you doing when it started? It woke me up from sleep. Oh, crap. Okay? And then I say, well, did you take anything for it? Yes, I took my nitro. It's not helping. Oh, crap. Okay? So you won't know the difference. The only way to know the difference is labs when you get to the ER, or you can get a 12 lead, and again, you can rule it in, but you can't rule it out on a 12 lead. So you could assist if you have an ALS partner, but ideally, we don't know, physicians don't know without proper lab work or, cath lab results. Kind of tricky, isn't it? When in doubt, treat it like an MI. Yes. Hands down, when in doubt, treat like an MI.
This is kind of like really, everything's kind of clicking now because I've had a few, at least like 3 or 4 patients who have come in and they're showing all these signs and symptoms, and in my head, all we've learned about is heart attacks. So I'm like, this guy's not having a heart attack, but on paper it seems like he is because he's having the chest pains and everything.
Sure.
So this is like, to me, like that time. This is like before that huge heart attack.
Yes.
That's exactly where they were. Like,
Yes.
I learned it tonight.
This is kind of that, hey guy, listen up, something's going on, change your diet, get some more exercise, do some stuff.
Yeah, something bad's gonna go on.
Yes, ma'am.
I'm kind of like with him because a lot of my patients, I've got a lot of chest pain since I've been out there, and almost all of them, I don't think are actually having a heart attack, and I had no idea what they were actually having. And one guy, the paramedic told me, I think he pulled some sort of a muscle up in this region.
Sometimes.
But I was like, I don't know, because and they asked me, do you think this person's having a heart attack? I'm like, well, no, but I can't tell you why. No, you know what I mean. So it's kind of nice to see the angina and the heart attack and where they fall because
Right.
I had no clue what was going on.
Did that guy who had pain, was it worse when he lifted or moved?
Yes. And see, I didn't know what that.
You didn't know the significance to it, right? Well, if I hurt my leg because I'm out running too much, when I move my legs, they hurt,
Yeah.
right?
Because he was a young guy, and the paramedic that was with me was like, do not think that because he's young he can't be having a heart attack.
Absolutely. Caveat, let me tell you guys something. Typically, cocaine is a cardiotoxic drug. So a lot of the times, if you see these young people with cardiac or heart attack history, not always, because sometimes, so I don't want you to think that every single young person who has a heart attack has a cocaine history. However, that is a huge leading factor in our young population who has a history of a heart attack or is having a heart attack. Okay? And, cocaine is a very expensive drug, so a little street knowledge for you. Cocaine is expensive. Rock cocaine or crack, dirty, not so expensive, still cocaine. Okay? You learned something else new today, right?
Yeah.
Excellent.
I didn't know crack and cocaine were the same thing. I knew cocaine was expensive.
Yep, it's dirty cocaine. It's not in powdered form.
I didn't know
Yeah,
that.
totally.
Crack is like, it's mixed with like household items.
It's mixed with Drano, with battery acid, with baking soda, with whatever. Which question?
It's like, it's a drug-related thing.
Oh,
Something
gosh.
was happening like in my clinicals. Both of them, each time I had like people come in like with bad runs with meth.
Yes.
One of
Yes.
them, the last time I was there, was a lady who was she was a drug dealer, got pulled over, had 2 different bags, each had $1,000 worth of meth in it, ate both of them, came in there foaming from the mouth and like a vegetable. She had like almost no brain activity going on.
Yeah.
She ate them?
She ate both of them as their
People will do that a lot to not get caught. If you don't get caught with possession, they can't charge you.
Yeah, but if you eat it.
It's gonna kill you.
Yeah.
Ma'am,
It was the last thing.
hang on, guys.
I have a kind of different question.
Okay.
I had a lady who came in presenting some of the signs of either angina or a AMI, but the physician said due to just some of the symptoms that were a little different, he thought maybe it was a TIA. What is the difference? Because he wouldn't, because they were triaged as stroke symptoms, but he said he didn't want to go as far as saying it was stroke symptoms. So what is
Stroke
TIA?
is in the head. Okay. And we're not there yet, so without getting too far ahead, stroke is, TIA is like a mini stroke or a transient ischemic attack. So it's kind of like angina of the heart. It passes, it doesn't last, it doesn't cause this damage. It's kind of impending of the big stroke coming.
I'm sorry, I thought there was a correlation because of the ischemic. I know it was transient ischemic, so I
Right.
figured there
The
was-
difference is that's head, this is heart. That's the only difference.
I'm so sorry.
No, you're fine. That's okay. Good question. No, he's not. Don't let him fool you. That's not nice, Sean.
I was confused.
He
I thought
rarely
it was
is.
something doing with the heart.
Obtain a history and get a physical exam. Okay? Physical exam. What are some of the things that we need to check on a physical exam?
If it's
It radiates, does it?
if touching the chest makes a pain increase.
Yeah, absolutely. What else? If they also are complaining of shortness of breath, what else do you think you might want to check? Breath sounds. Absolutely, and we're going to learn about why we're going to check for edema in the feet in a little bit. We also want to check for edema in the feet, or pedal edema.
So if they're wearing shoes, you should take their shoes off?
No, I'll look above it. I'll look above their shoes.
Okay. I was just curious.
If they're at home and they're wearing house shoes, and you take it off and it looks like they're still wearing their house shoes, that's positive pitting edema. I'll explain later.
No, I mean, I've had that happen to me. I don't
You're not having a heart attack.
I didn't think so. They gave me a diuretic and it went away.
Yeah, you probably just got fluid overload. So aspirin, 325 milligrams. Now, here's the deal, right? Some people carry baby aspirin, which is 81 milligrams apiece, okay, versus the one big baby versus the one big regular aspirin, which is 325. So if the protocol says, what do you think it's going to say? If you're going to give 81 milligram aspirins, how many are you going to give?
4 and you shave a little bit off one.
No, you don't shave a little bit off one, but good call. So you're going to give 4, and you're going to get 324 milligrams. Now, this is going to be different based on the service that you work for. They might go 3, they might say 2. Okay? For our intents and purposes, 325. Sir?
We are allowed as basics to give Bayer or aspirin.
Yes. Depending on the protocols that you work under. Okay?
And nitro too, right?
Say again?
And nitro
Yes.
too,
Yes.
right? That blew my mind.
Depends on the service that you work for.
Well, I mean, because I volunteer out at Huddle, and when I was going through their bags and everything, their medical bag, I see nitro in there. And I'm like, what is this doing in here?
We could have a whole nother discussion about whether they're ALS or BLS, first responder or certification. I will tell you, and again, the college is 325, but when you're out there and you're riding out with Scott and White, their first responder agencies, unless they can start a line, cannot give nitroglycerin. Okay, because if they're having a right-sided heart attack, you give them nitroglycerin. You're not getting their blood pressure back. Okay? It has a significant effect on the clot formation. Understand this about aspirin. It is not a blood thinner. It does not thin the blood. So here's what it does. It makes the platelets less sticky, or it makes them slick, so they don't stick to those plaque formations. Remember how we talked about that a little bit ago?
Yes, ma'am.
Okay, that's what it does. That's how it works in this case. Okay?
Does Vader work the same way?
Yes, it's aspirin.
Oh.
Yep.
So, like if you got a headache and you take it instead of Advil, is that bad?
No, some people have reactions to aspirin, and we'll talk about that when we get into aspirin.
Okay.
And that's going to come up here pretty quick.
Okay.
So, say again?
A lot of people are taking aspirin now.
Yes.
Like, it's part of what meds do you take? Oh, well, I take a baby aspirin every day.
Yep. They do it a lot prophylactically now. Also, you're going to give nitroglycerin, 0.4 milligrams sublingual. Now, this says tablet sublingual. Be advised, it comes in other forms. So if you're already doing ride-outs and they're having chest pain, you will note that a lot of places do spray. They have nitro spray as well. Nitro comes in several different forms, and we'll talk about that during the nitro lecture. Okay? You do need to know your doses, your indications, your contraindications, your side effects of all of the drugs that you're allowed to give. I'm telling you fair warning for pop quizzes. Okay? Ask about ED meds. What is an ED med? Somebody who wasn't in the class before. What is an ED med? Rachel. Erectile dysfunction. This is going to be your Viagra, your Cialis, your Levitra, any of those things. Do you know why? They vasodilate. That's how they work. All right? So if they vasodilate and we give you more medicine to vasodilate, what happens?
You're wide open.
You're wide open, right? We know some shocks that do that too, don't we? Okay, so then you get relative. That's a pipe problem, remember? Pipes are fluid. Good. Your patient needs to be sitting or lying down. Okay, that's pretty important. Okay, so you want to know, have you taken any nitro in the last 10 minutes? If they have, did it relieve your pain? Did you get a headache? Headache is a normal side effect for nitroglycerin. So if they carry around their nitro all the time, and it may or may not be in date, we don't know, chances are if it didn't tingle under their tongue and it didn't give them a headache and it didn't relieve their pain, it was probably because it may have been bad nitro. Okay? But we still need to note that. We need to note what was given to the patient, whether the patient did it themselves or by someone else, right? And what were the effects. Okay? And is the BP over 100 systolic? Again, if this vasodilates, what should happen to my blood pressure? What should I expect to happen to my blood pressure? Yeah, it should drop. So if it's already 100 systolic and I drop that blood pressure, okay, that's bad. All right? And then you can do it every 5 minutes. Q, like this. Sometimes we'll have a line over it, but Q, 5 minutes means every 5 minutes. The Q is every. Okay? So every 5 minutes until pain is relieved or until you reach the max dose.
So if you're doing it every 5 minutes, do you check their blood pressure every 5 minutes?
Oh, yeah.
And then what happens? I mean, if it goes, you give it to them, blood pressure's good. 5 minutes, give it to them, blood pressure goes to shit. What do you do?
Don't give them any more nitro.
Okay.
What is the max of nitro?
It's going to depend on where you're at. Most of the time it's 3. 3 of your own nitro. Yep. Generally, the thought is, generally, if it hasn't kind of worked by then, it's probably not going to. Okay, and then we kind of move on to stiffer medications, which y'all cannot give. Sir?
Is the paramedic allowed to do like a nitro, like a drip?
Yes. Yep.
With that every 5 minutes, so we have to get permission from medical direction first before we can start giving every 5 minutes.
It is going to depend on what your protocols say. Most of your protocols will say you may administer nitroglycerin as long as chest pain persists and blood pressure remains above 100 up to 3 times before consulting medical control. So a lot of them will allow you to give it that 3 times, and then if it doesn't work then you need to call medical control and go, hey, look, I've tried 3 times. What would you like me to give? Okay? Transport in a semi-sitting position, which we kind of already talked about, if the BP is normal or elevated. If it is low, transport them flat. Don't put them in the shock position. Do you guys understand why?
Because if you have them in the shock position, all that blood's rushing back to the
And you increase the workload on the heart, therefore increasing the need for oxygen, which we already have a problem with. Right? This is a supply and demand problem. The heart's demanding more oxygen. I don't want to put any more demand on the heart that it needs more that I already can't supply it. Everybody understand? Jesse, are you with me? Okay. Early notification of the hospital is important. This is extremely important. Don't walk your patient to the ambulance. Why?
Physical exertion.
Yep, it exerts the heart, therefore increasing the demand of oxygen that I already can't provide. Do not use lights and siren as long as the patient's awake, alert, and breathing without distress. Now, yeah, you don't want to increase that stress and anxiety level. Okay? Monitor vital signs every 5 to 10 minutes. And again, if you're giving nitro, it needs to be every 5 minutes. Okay? I need to make sure I haven't dropped the blood pressure so much that I shouldn't give another one. Request ALS backup early. All right? 12 lead helps determine treatment, okay, which we've already kind of talked about a little bit. Generally, if you die from having a heart attack, it's from the arrhythmias, or irregular heart rhythms, or funny little beats, okay, FLBs, funny little beats. Paramedics can sometimes use medication to address those arrhythmias before death ensues, which is...
So when you say it's going to make you feel like crap.
That's adenosine,
Yeah.
and no, generally we don't give that for heart attacks. Okay, arrhythmias can be prevented, like I said, with early drug. Okay, all right, hypertension. This can be a chronic or acute event. Now, before I move on, do you have any questions about cardiac? You know, MI, angina, unstable angina, etc. No?
Always consider it like that. By my rule, it's all I look at.
Right.
And maybe it's just like in there.
Yeah.
How I look at it.
Especially at a basic level, you need to assume that it's an MI. Okay? All right, so hypertension can be chronic or acute, kind of like what we talked about. So pathophysiology. So basically it increases the pressure to the organs, which is why a lot of people, if they have uncontrolled hypertension, will end up on renal dialysis because it destroys their kidneys. The kidneys can't have that high perfusion, that high pressure. Okay? So it kind of destroys their kidneys. All right? Reduces the blood flow and then increases the afterload on the heart. All right? It's an emergency if the systolic pressure is greater than 160 or the diastolic is greater than 94. Okay? They need to be symptomatic, though. All right?
Does that really apply for somebody that's really, really old? And the reason I asked this is because we had a lady that was 100 and her blood pressure was like really stupid high, and they told me like, don't worry about it, it doesn't mean anything. Her blood pressure can be that high. Is that true or false?
I would be inclined to say false.
Okay.
Yeah, typically the people who are elder, especially depending on size and weight, tend to be on the lower side of things. And if they have any kind of cardiac history, they're usually on a beta blocker that controls that and keeps it nice and low.
So I actually should have been concerned about this lady's blood pressure?
Well, I mean, yes and no.
Okay.
So does she have a history? Is this kind of her normal?
Well, she had, this is the other thing, she hit her head. So But I mean, they just said in general that not to work. That's why I asked. It's not in direct correlation with her issues, but they told me that when you're that old, your blood pressure can be that high.
Typically, they're usually controlled and kept low.
Okay.
But, I mean, they can have hypertension.
Okay. I was just
But
curious.
even if it's high, it's still cause for concern. It probably needs to be addressed and treated.
Okay.
Okay? All right. So signs and symptoms. Strong bounding pulse, flushed skin, skin can be dry or moist, headaches. Headaches are very common in hypertension. Okay? Also ringing in the ears, nausea and vomiting, and nosebleeds. Nosebleeds are pretty significant, okay, because your membranes on your nose is real thin, and so if you have real high pressure, you can kind of pop some. Yeah, you can pop some of those. That's why they get nosebleeds if they have high blood pressure. Okay. If you ever pick anybody up at dialysis and they can't get the bleeding to stop from their shunt, they probably have high blood pressure. Their blood pressure is probably too high.
Now, what about those people that live with hypertension and that don't take medications for it? I had one patient that basically she was 220 over 110 or something like that.
She's going to stroke.
Yeah, well, she's been living like that for 2 years.
Yeah, it's just a matter of time. I mean, quite honestly,
Okay, well, the reason I'm getting to is like the signs and symptoms. She did show a headache.
Sure.
She didn't have anything else. Her pulse was normal.
yeah,
Like it wasn't bounding. It wasn't anything like that. It was just completely normal.
it can be.
And it's like how, yeah. So, okay, whatever.
I feel bad for her. I don't know why she would live with that headache.
Yeah, and in the end, she is going to cause damage. Like I said, she'll cause damage to her kidneys. She will probably end up having a big stroke. Yeah. So management. History and physical, supportive care, so position of comfort, oxygen. What does it mean if indicated? Below 94, okay, 94 below. And request ALS because they may be able to give her something to lower their blood pressure if they're having a hypertensive crisis or hypertensive issue. Congestive heart failure. Everybody get by your diagrams, okay? This is basically the inability of the blood to pump as fast as it's receiving it, okay? So what might cause or what might be a significant factor in my heart's ability to pump? MI, an old MI that's caused death of a heart muscle. So it can be an old MI or a new MI, either one. Okay? So we have left-sided and we have right-sided. And we have both. Okay? So look at your diagrams. Look at your models. What do you think some of the causes? So raise your hand if you think you know. If you've been in this class and had this part before, let some of your other guys work on it, okay? So, what do you think some of the causes are for congestive heart failure?
Diseases of the lung.
Coronary artery disease, atherosclerosis, let's see, chronic hypertension. Okay, there's another problem with that woman, Sean, who's going to live with her pressure high up there. So her blood's pumping to her heart faster than her heart's able to get it out. Okay, MI.
What exactly is coronary artery disease?
It's narrowing of the lumen.
Okay.
Yep. Valvular heart disease. So those valves that are in your heart, if they're diseased, then clearly it's going to affect the heart's ability to pump. Okay? They're not opening and closing appropriately, so the blood can move through the heart as it should. Okay? Usually begins with left-sided failure, so look at your stuff here. Okay? If my left heart fails, where does my blood go? Back into the lungs. Does everybody see that? So follow your model. Okay, has everybody kind of traced it back and understand why left-sided heart failure causes? Okay, is why it's usually the start. Okay, increases the workload on the ventricle, that left ventricle, right? And there's this theory before I broke my rubber band. Okay, and this basically says the further I stretch my rubber band, the greater the pop, up to a point, right? Because eventually I'm going to stretch out my rubber band and it's not going to be as stretchy. It's not going to have that elastic. It's going to affect the kick. Does that make sense? You with me, Cody? All right, so then the left ventricle is going to fail. And again, blood stacks up in the lungs. Does everybody see that? Yes. Then you get high pressure in those capillary beds. So find your capillary beds in your lungs, i.e. the purple spots in the lungs, right? Because that's where gas exchange happens in our models. Are you with me? Okay. Are these our lungs? Excellent. All right. And so what happens when those capillary beds get under high pressure?
They burst, right?
A little bit. Where does the blood go?
Everywhere.
Well, we're already in the lung because the capillary beds are in the lungs. What does it go to? The alveoli. All right? So what happens when we get fluid? What happens when we get blood from those ruptured capillary beds in our alveoli? Well, of course it's not good. Who said that? Of course it's not good. What happens? Yeah, it affects gas exchange, right? That's the whole idea, is it's going to affect my gas exchange. All right? Right-sided heart failure is most common, caused by left-sided heart failure. How the heck does that work? Domino effect. Domino effect. So trace it around. So it starts on my left ventricle, right? I back up into my lungs. Yeah, left atrium and then to what? Okay, the lungs. Then what? Yep, then it goes back into that right ventricle. And now I'm getting the stretch on my right ventricle, right? It's got too much blood. I can't do it, so I'm going to start kind of failing. It's kind of like you ever see the more work you have, the more work you get, and eventually you're going to kind of fail at something. You're going to drop something, right? The more the paperwork stacks up, the slower you're going to get at getting stuff turned out because you got more to do. Does that make sense? Same concept with the right side of the heart.
When you get that too, you can start getting narrowing the BPs, right? Or am I thinking narrowing blood pressures?
Generally, you're going to get higher blood pressure because they're trying to pump more blood, right? Okay. It does cause JBD. What else does it cause?
That edema you were talking about.
It causes pedal edema every time, okay? But this pedal edema is going to be able to tell me whether it's acute or not acute. Some people will have pedal edema all the time. I look at them and go, "Are your feet always swollen?" And they go, "Oh yeah, honey, that's all the time." Right? That's probably more of a chronic thing. If they say, "No, I started having chest pain within a couple hours, then I started having trouble breathing, and now my feet are swollen," what's likely the cause?
Stage F.
They're probably having a left-sided heart attack. Because where did it start? I started having chest pain. Where's the first thing I said happened? I started having this chest pain, and then I started having trouble breathing. I just couldn't catch my breath.
Started affecting these lungs.
There you go. So follow it back around. Does that make sense? Cody, are you with me? Okay.
Why does it get back to your feet though? What is the...
Well,
Blood goes through the entire body.
that's right. My blood flows through my entire body. So find your model. Why aren't you with your group?
Because I was writing there.
Take your paper with you. Come on. Okay? So, what happens at my purple areas? What do we know about that? Well, okay, so it's where gas exchange happens, and that happens kind of all over. What else do we know about that transition? So when it goes from my red pipes, what are my red pipes? Who said it? What else? High pressure system. So I'm going from a high pressure system. What happens when I hit my capillary beds? What happens to my pressure? Drop my pressure. So now they're pushing it quick here, but I'm not so quick at getting it back up because it's a low pressure system.
Wouldn't you have edema in hands and other places?
You can. Why do they generally get edema in their feet? Gravity. We tend to be upright animals. Okay? These people who have congestive heart failure, and I know we're getting way ahead, but I like the discussion and where we're going. So these people that end up having this left-sided heart failure and get this backup of blood, we already talked about in the lungs, where it ruptures the capillary beds and moves into alveoli, and I can't breathe. When do you think they have a hard time? When do you think their shortness of breath is the worst?
After the rupture.
What time of day?
Because they're laying down.
When they're laying down. So what do you think you'll see when you walk into the house of somebody who's having exacerbation of or worsening of their congestive heart failure?
Sitting up in the chair.
What else? Lots of pillows. You'll see lots of pillows on their bed. They're going to be sitting up in their recliner. You guys are giving me goosebumps because you're getting it. So they're going to be sitting up. They're going to be sitting up in their recliner. They're going to have lots of pillows, right? Those feet might not be so swollen. They can actually get edema in their butt.
Really?
Depending on, because it's all position dependent. Sir?
With this CHF, would it be more ischemic or is it going to be more of an infarction? I mean,
I'm not following you.
like
It doesn't have.
It's a failure. Could it have the potential to restore, or is that failure done?
This failure is typically left heart failure. So
Right.
when the left heart fails, usually, now this isn't always, okay? Usually they've had a heart attack. Well, what do we know about a heart attack? After we've talked already today, what do we know about heart attack? Death of a heart muscle.
Okay.
And that can't be repaired. So
This is a chronic problem.
it absolutely can be chronic, but once you get it, you've got it.
Yeah.
Usually they will say, I've had a heart attack within the last couple months. This has never happened to me before. Or they're going to tell you, I have congestive heart failure. This happens all the time. I can't breathe.
So this is always after.
With or after a heart attack, usually if it's left-sided heart failure. But remember, there are some other causes. What were the other causes we just talked about? Artery disease, hypertension.
Have you seen that commercial with the lady that's got the elephant sitting on her chest?
COPD.
Yeah, that's a COPD
Oh,
commercial.
was it? I thought it was a this.
That's an ongoing inhaler kind of thing.
My bad.
All right.
Congestive heart failure. Say like, what is it like?
So once you have congestive heart failure, you're always going to have it. You're not always going to be congested. Okay? The congestion of the heart failure is a symptom of the failing heart itself, or the damage that was done to the heart, or the hypertension, or whatever. Right? This is the result of another problem.
So it isn't perfect.
I was just wondering about.
Well, not always,
Not always.
but the heart has damage,
Right.
generally. Not always, though, right? Because hypertension can do it too. But once the heart is damaged,
So you can treat it, you can't cure it.
that's exactly right. So we focus on treatment. We focus on keeping their blood pressure down and making sure we have enough workload, that we decrease the workload on the heart, which is really what we're talking about when we're talking about blood pressure, right? We want to keep their blood pressure and their heart rate at a good, nice, even level so that they don't outwork their heart. Does that make sense?
Yep.
All right, let's see where we're at here. They will get the distended neck veins like Jesse had talked about, or they could. They can actually get fluid in their abdominal cavity. So depending on how far they back up, you can have some of these guys with big, hard bellies that are full of fluid. Or mid-thigh, and you can sometimes track it. You can sometimes track up how full of fluid they are. They can go mid-thigh, or they can go all the way into their thigh or into their abdomen.
Is it going to be blood? Or is it
Yes.
Gonna be, okay.
Well, and that's another thing they might want to do with congestive heart failure, right? They might want to limit their fluids Because when you increase the fluid, you're going to increase the workload. Okay? Pedal edema, which we already talked about, and that's because it's position dependent. All right. Symptoms of congestive heart failure. Inevitably, I learn quickly that anytime I go to an elderly person's house and they have had a history of a heart attack and they complain to me of, I'm just feeling so weak. I haven't been able to sleep for 2 or 3 nights. I almost always went with this initially to see if I could rule it in or rule it out. That was kind of a place to start, right? Weakness is a very, very vague symptom. Here you go. All right? Dyspnea, shortness of breath. We know why that is, right? Okay. Dyspnea on exertion. Why is that? Why do I have a harder time breathing when I exert myself? Yep, you're increasing the workload of the heart and you're increasing the amount of fluid in the lungs.
With the shortness of breath, is that going to be something that even when it's like, I guess in this zen place and you're not really having any problems, that you're still going to have?
Sometimes.
Okay.
Sometimes. So when you exert yourself, not only does your heart require more oxygen, so you're going to have to breathe harder and faster, and your heart's working harder and faster to supply it. Now you're also increasing the possibility for increased fluid in the lungs. Okay? So this is like a big vicious circle. One causes another, causes another. Okay? What does that mean? Attacks of shortness of breath that usually occur at night and awake the patient from sleep. Right? Then what happens? They're laying down and they wake up because they feel like they can't hardly breathe. And they sit up for a while. They start feeling a little bit better.
Sleep apnea? I mean, it's kind of the same thing.
No.
Sleep apnea is when you stop breathing.
Okay? But the idea is that when it wakes them from sleep, what do you think you do? You sit up. What happens to fluid when I sit up? It goes into the bases, so it gives me more lung for gas exchange.
So would you find that these people might often sleep in their recliners?
Yes, ma'am. During an exacerbation, so during a worsening of this condition.
So in a clinical setting, if you are anywhere suspicious of CHF, you would want to make sure they are sitting upright and not laying down?
Well, it's going to depend on their complaints, what they're kind of complaining of. So if their complaints are this, because remember, this is going to be part of their history and their, so yeah, they're going to want to sit up and you don't want to lay them down because then it's harder for them to breathe. It's harder for them to make gas exchange and they feel like they're suffocating. They will want to sit up and you will want them to sit up.
Would there be any lung sounds due to the fluid?
We're going to get there. What do you think you're going to hear?
I'm asking because I had a patient, we thought it was CHF, and when I listened to his lungs, I heard wheezing. Kind of like a fluid movement in there. And like
That's not wheezing. Fluid movement is not wheezing. What's it called? Rails.
So I had a patient, and she was on a steady nitro drip
Mm-hmm.
because of it. 'Cause
Yeah.
She was
So-
like 80 and her blood pressure was like 190 something.
And they were trying to open up her vessels and her pressure was high because she was trying to move the blood to get it out of her lungs. So they give him nitro, open up the tank, hopefully make some more room for the tank to hold the blood instead of the lungs.
that fits mine perfectly because they gave him nitro,
Yep.
had high blood pressure, came back later, it was lower because of the nitro.
Yep. Orthopenia. What is orthopenia?
Difficulty breathing. Any position other than standing up. Or standing or sitting.
Yep. Difficulty breathing in any position other than standing or sitting. Gee, I wonder where they got that answer.
Hey, no one else is saying anything.
Abdominal discomfort. Okay, because they're going to be kind of bogged down. JVD. They may have JVD. Okay. And then that pitting edema in their feet. Some of those people, like I said, they will have that pitting edema all the time. And so you may be there for something completely unrelated and you're going to kind of look at their feet and go, is it always like, oh yeah, it's always like this. Oh, do you have congestive heart failure? Oh yeah. No matter what you're there for today. Okay. Tachycardia. Why is the heart beating faster?
Pumping harder.
It's trying to get rid of it, right? It's coming in, I gotta get rid of it. Pulmonary edema. What does that mean?
Swelling.
Nope. Mickey, what is pulmonary? I know I picked on you and you got a mouthful. I'm sorry. What is pulmonary edema?
Is that when fluid's building up in the alveoli?
Yep. Fluid in the lungs. Remember, pulmonary means lung. Yes, sir.
If they're great, that won't happen in the lady that the capture built came in pulse 30. And
Well, okay, so is it a cardiac problem, right? Because if your heart's not beating fast enough, what's going to happen to the blood? If my heart's only beating 30 times a minute and I need to beat 60 times a minute to move all the blood, it's going to get backed up still, right? So there are other reasons to have pulmonary edema. I don't want you to think that congestive heart failure is the only reason for pulmonary edema, because it's not.
they laid her down.
But she was unresponsive, right?
She was responsible to pain.
Yeah, she probably couldn't sit it very well, couldn't hold herself up very well.
Or she was in the bed.
Mhm.
She's a DNR, so I don't know if she'll die.
But remember, there are other reasons for pulmonary edema. So that low heart rate can actually be a result of, or a complicating factor of. Okay? Noisy, loud, labored breathing. Okay? Coughing. They're going to be coughing a lot, sometimes. Rails or wheezing. What do rails sound like? If you've got hair, take your hair down here by your ear and rub it together. Do you hear the little crackles?
I found that on the ambulance it is very hard to hear anything.
Yes. One of the things you can do is don't put your feet on the floor. Pick your feet up and put them on the stretcher when you're trying to get a blood pressure. You should be able to hear a little bit better. Noise doesn't transmit so better as well.
I will
Try that and see.
I will.
All right, so they could have rails or wheezing.
Is that on inhalation or does it matter? Exhalation?
Generally, wheezing is inhalation.
For rails?
I'm going to have to think about it for a minute. I think rails can be either.
Okay.
And I think I've got some recordings that we can try to listen to. YouTube actually has a good lung sounds, because there's a lot of educational places that populate on YouTube. So you can go in there and find rails, lung sounds, rails, or wheezing, and it should give you a pretty good listen. Pink frothy sputum. Why is that, Destiny?
Oh, I was thinking if I had seen any of that with the gentleman that we were thinking it was CHF. I think that'd be something that'd be a very pertinent key indicator of it. Would it?
This is a late sign.
It's a late sign. Now?
Late sign.
Okay.
Why do you think they have pink frothy sputum? What do you think that is?
I'm not sure.
What's in their lungs?
Blood.
Blood.
So when all the sputum and stuff comes up, so does the blood tinge.
Yep. Yep. Absolutely. And like I said, this is typically a late sign. Okay? All right, so let's talk about some heart failure signs and symptoms. Mild to severe confusion. Why are they confused? Yeah, because they're hypoperfusion, even to the brain. They're not getting enough oxygen to the brain. It doesn't function properly. They get cyanotic, okay? Tachypnea, which is fast breathing, okay? May cough up, pink frothy sputum. Low, normal, or high blood pressure. This is going to depend kind of how far into this stuff they are, okay? A rapid heart rate. Again, let's move this blood. Let's get it out of here. Desire to sit upright. Look at her feet and legs.
Very swollen.
Yeah. Pedal and lower extremity edema. Now, it doesn't have to be in their feet, but typically it is in their feet and their lower extremities, because remember, they have the desire to sit up because they feel like they're suffocating and can't breathe. Okay? May have abdominal distension. Again, that's blood backing up there too. Okay, it's just a little harder to see it sometimes in the abdomen. All right, pale, cool, clammy skin, shortness of breath, crackles. Okay, remember it sounded like crackles. If you didn't get to hear it and you want to hear it, come see me. All right, distended neck veins are also a very late sign. Okay, and then they're going to be anxious. What does that sound like? It sounds kind of like shock, although their pressure can be high, but essentially they're just not perfusing the brain very well. They're not oxygenating the brain very well. So anxiety, confusion, cyanosis are all kind of thoughts of they're not getting enough oxygen to the melon. Okay? What are we going to do for these guys? Sit them upright, let them dangle if you can. Kind of hard to do in the ambulance because you can't appropriately secure your patient. Okay? Maintain oxygen levels of 94. CPAP or PEEP. Right? Have we talked much about CPAP? Maybe we'll get the opportunity to talk about it this evening. We'll have to see kind of what our timeline looks like. So remind me. Okay? Monitor the vital signs every 5 to 10 minutes. Request the ALS backup early. Okay. Questions on that? Okay. Did building the models help you kind of understand this process?
I actually liked building models.
We'll talk more afterwards. Okay. So, pacemaker failure. We're going to put them in a position of comfort. Make sure they have a patent airway. Oxygen to maintain 94%. Are we seeing kind of a pattern here in this? Okay. Assist ventilations as needed. Get ALS to intercept. Okay. CPR is needed. Don't worry about damage to the pacemaker. Okay? If you don't do CPR, they're going to die. Ma'am.
This may be kind of a random question, but on the ALS, since, like, if you write out Wisconsin Life, that's open right now, like, don't they always have a paramedic? So, don't you always have ALS?
No. You guys are put with ALS people. Scott and White has BLS trucks as well.
Oh.
They typically do interfacility transfers. However, the way their system is set up, they occasionally will respond to a 911 call while they're waiting for either a supervisor or office staff that are paramedics to go assist. All right? And that's just here. So in New Jersey, when I worked there, it's a tiered system. Only EMTs are on the ambulance. Paramedics drive in flat cars, is what they call them. Excursions, expeditions, something like that. Expeditions, I think they were. With equipment, and they get on with the BLS units. But the BLS units could go, yes, I need them, or no, I don't, based on dispatch information and patient presentation. Okay?
Wouldn't that kind of be like not good in some situations? If you get there, and then by the time the paramedic gets there,
We rendezvoused a lot.
okay. We're saying when it wastes a lot of time getting to it.
Well, no, okay, so in a tiered system, they didn't wait for us to, for EMTs to get on scene and make that determination based on the complaints. So chest pain, seizure, trauma, unresponsive, those kind of calls automatically got both sent. Was that what you were asking?
Yeah.
Okay. So implanted defibrillator. If performing CPR on the patient, the defibrillator may fire. Okay? So you may feel a slight tingle. It's a very low because it's directly, invading the heart. Okay? Cardiogenic shock is inadequate tissue perfusion related to heart. Okay? So basically this is inability of the heart to pump. So a lot of these things that we've talked about will eventually go into cardiogenic shock, right? Think about your left-sided heart failure. Okay? Eventually they're going to go into this. So causes. MI. Valve failure. Are you seeing kind of a correlation here? Tachycardia. Bradycardia. What is that? I know the word. What does it mean?
Fluid.
Yeah. What? The sac around the heart fills up with fluid. Okay. All right. Signs and symptoms: altered mental status, pale, cool skin, delayed cap refill, others based on the cause. So if they're having an MI, then they're going to be presenting with MI stuff and all of this. Okay? So to request ALS, position them supine, open the airway, assist ventilations. These people are sick. Okay? This isn't, well, do I set them up? No, because they are probably already in failure. We're beyond setting them up and trying to work through this. Okay? Assist ventilations, keep their O2 sats above 94%. Make sure you cover them, transport them quickly. Okay? Post-cardiac arrest. So what do we do after they've arrested? Reassess the patients, maintain the airway, oxygen above 94%, and rapid transport. If you work with, most of your ALS units now do hypothermic therapy, so they use cooled solutions, proven to be extremely effective on the outcome in a post-arrest situation, as long as they're adults and it's not due to shock, due to blood loss.
What does that do? Is it like ice bagging the heart or something?
Kind of. Questions?